thromboembolism in the context of COVID-19 infection. Dr. Simon, there are concerns about increasing PE in COVID patients. What are your views on this topic?
The coronavirus pandemic has thrown up several issues around venous thromboembolic disease and pulmonary embolism. A lot of patients, even if they are at home, they are unwell and they are bedridden. Again, whilst they are inpatients with this severe infection, they are bedridden. As we are aware, there are a large number of patients who suffer from venous thromboembolic disease and indeed death during in-hospital stay despite best anticoagulation strategies. Now, the published data on COVID-19 infection suggests that it is a procoagulant state with increased factor 8, 1 milligrams factor and fibrinogen, leading to increased risk of thrombosis. One of the laboratory tests which shows these changes, which is routinely used, would be a D-dimer. The D-dimer is often high, in the tune of 1,000 to 2,000, and for severely ill patients, 5,000 to 10,000. Now, in patients with COVID-19 who are hospitalized, and if their platelet count is above 30,000 and if they do not have any bleeding symptoms, they should be anticoagulated. There is a debate on whether we should increase the dose of anticoagulation in the setting of prothrombotic stage. The Imperial College has suggested doubling the dose of anticoagulation. After review of literature from the American Society of Hematology and the International Society of Thrombosis, our clinical advisory group on COVID-19 has decided to take a D-dimer based approach. If the D-dimer is more than 1,000, which suggests a procoagulant stage in the patient's journey, we would double the dose of anticoagulation with low molecular weight heparin. However, in renal patients, considering the risk of bleeding, if the creatinine clearance is less than 30 ml per minute, we would keep the anticoagulation dose the same. We have also used weight-based low molecular weight heparin dosage to cover for people who might have high body mass index. And we would also recommend testing the D-dimer if there is a rapid clinical deterioration in these patients. An increase in D-dimer would be a trigger to increase the dose of anticoagulation. And I would again emphasize the need to change from NOACs, that is apixaban, rivaroxaban, edoxaban, in patients who are already on it for other indications, to low molecular weight heparin if there is a clinical deterioration. Thank you.
Thank you.